It's imperative to understand that what you put into your body can help you or hurt you.
Welcome, everybody, to GNI Podcast. I'm Dr. Erol Veznedaroglu, part of GNI, and we are going to be talking today about neck pain and back pain. Huge topic, 30,000 feet, and we're really privileged and honored to have Dr. Brynn Previti from AtlantiCare. She is the Director of Rehabilitation Services, but more important than titles, been working with Brynn for a little over a year now, hands-on, inpatient, outpatient. She rounds with us first thing in the morning from the sickest spinal cord injury patients in the ICU to patients who are being admitted for exacerbations of back pain and neck pain. So today we're going to be talking about what it is and management. And I think this being a neurosurgical service and a clinical service line, I think the listeners will be surprised to hear the approach that I'm taking. And this is about education and how to help patients. So, with that, what I'd like to start off with is, we both see a ton of patients with pain, right? Yes. Neck pain, back pain, hip pain, shoulder pain, all of it. But we were talking about before we started the podcast and laughing. I asked Dr. Previti, how many patients or how many people do you hear from a week asking you about advice on neck pain, back pain? And you were saying that, you can't get through the hallways without people that you work with, family, friends, right?
That's correct. Yeah, it's a constant conversation. I talk to colleagues, peers through the halls of work every day. And yeah, I'm reached out to in my personal life from friends and family, and it's a constant conversation.
Yeah. Likewise. And so what percentage of patients would you think that ask you about this, do you think are getting the right advice or are being directed in the right direction?
Based on my opinions and knowledge and experiential knowledge, very, very slim percentage, next to none.
Yeah. And I would echo that. Same on my part. I am a neurosurgeon, and I trained at Jefferson with the region's at the time only spinal cord injury center. I trained under Dick Rothman as well as Fred Simeone, for our older listeners out there. He was the king of spine in Philadelphia for a very long time. And if you had back problems, you went to Fred. I don't currently do spine surgery, but I am a neurosurgeon, and I've, God knows, done enough. I used to have carpal tunnel from all the times we do the rongeur of like taking bone off. So I'm looking at this very objectively from a surgeon standpoint and somebody who does deal with patients with these issues all the time. And I would say that it's a real problem. And so what I'd like to do, and I think the goal of this podcast is education, and really steering patients in the right direction and giving them some tips and some help. We were talking earlier, I know many people and many physicians don't know, and I'll pose this as a question to our listeners. Do you think if you have a ruptured disc, and if we can, we have a video up, and you can look, and as you can see, this is a ruptured disc in your vertebral column compressing a nerve root, and you can see where that red is. So on the left here, on the opposite side, is a normal nerve root. You can see there's two roots. There's motor, sensory, and that's healthy. It's wide open. It's coming out what we call foramen. And then if you look on the right, on the opposite side where that red is, that's a nerve root that's being compressed by a disc. This is what we call a herniated disc. And this is the technical term is radiculopathy. So what would you think? You see that big disc, it's a big fragment, anatomically compressing a nerve root, squashing it.
Yep. So
the question would be physical therapy versus surgery of removing that at 6 months, who does better? So is it opens, and I wish we could do, actually maybe in the future we'll do this where we can kind of have call-ins and
Sure.
show. I think most people and most physicians don't know that at 6 months, patients do better with physical therapy.
Conservative treatment wins.
Conservative treatment. So tell our audience, what is that? What is you see this patient, what is your treatment for that from physical therapy, non-surgical?
So there's a really deep interview process, and there's a really good look at the patient because it's individualized, right? Nerve pain and anything neurological is not cookie cutter.
Right.
There's some predictability, which makes it a little bit, I guess, gives you a little bit more power to treat and know what interventions could potentially work, which direction to go in. But every patient deserves a really deep look into their specific case. So what brought this pain on? Do you have any comorbidities? Is there an event that led up to this? What are you limited in doing in your life? Are you losing quality? Tell me about your symptoms. Describe them in depth as much as you possibly can. Nerve pain sometimes is really difficult to describe, but if you ask the right questions and you have a listening ear, you typically can get to solutions quickly. So for conservative treatment, it would be a really good look at this patient. Are there postural issues? Did this occur because of repetitive movements, or is it occupationally related? Do we have to look at ergonomics and kind of make an assessment there? Are you a healthy weight? Are you eating well? Really kind of honing in on the origin of what caused this pain to occur and these symptoms. And then there's really skilled interventions and lots of options and opportunity to treat something like this in the clinic.
Okay. So let's start with a real patient.
Okay.
So I'm going to give a real patient. And I want to get the audience to kind of get a sense of the way it should be, the communication between, which I think we do have a very unique setup at AtlantiCare with us, with the neurosurgeons at GNI, and you and I speak a lot about individual patients and treatment plans and all of that. So let's talk about a real patient. So I have a patient who is 55 years old, very healthy female, exercises every day, perfect weight, perfect everything, really no major health issues. And all of a sudden started having neck pain. Didn't think much of it. And, just basically kind of went on and was not doing anything, then started using non-steroidals because the neck pain got more and more. Then the neck pain started turning into arm pain, shooting down the arm. And she basically got to the point where she went to her physician and said, look, I'm worried. Like now I'm getting arm pain and it's getting worse. It's worse at night. I literally, it's exacerbated. I work at a computer. I'm sitting, I do Zooms all day. That's when it's worse, but nothing's really helping this. MRI was done and it showed basically showed a nerve root compression. What is your management for that patient?
So we're going to look and see if there's anything compensatory. Are you symmetric? We're going to do a deep dive into the tasks that exacerbate the pain. I'm going to look at the biomechanics and see how the patient's moving. Again, are there any asymmetries? Where's their weakness? Where's there a deficit? What can we tap into? I mean, this is a dream patient. She's healthy. She takes great care of herself. There's a lot of opportunity to not cut this patient and see some real functional turnaround and real handle over these pain symptoms.
So what are your recommendations for that patient? So as far as, obviously it's going to be physical therapy.
Yes.
So what is that? Because it's always surprising to me. And again, physicians as well, unless they've done it themselves for some reason or had a family member. What is a typical, so that evaluation's done, there's a discussion that, we're not worried about anything surgical. There's no spinal cord compression. There's no what we call myelopathy, meaning hand weakness, things that would be worrisome. This is just inflammation of that nerve root. What are some of the techniques that are being done as far as, physical therapy in the actual gym or in the actual physical therapy center versus what you're having them do at home or in conjunction?
So I can speak to, starting at the bedside. I'm an acute therapist. These patients do come in often. They have this severe increase in pain. They come in and, like you said, they get MRIs and films and things like that. We can start right there, and we often do. It doesn't have to just be outpatient. I take a look at their posture, make some very simple corrections, give them slouch correct, appropriate chin tucks, let them know we do some mirroring where they can actually take a look and see if there's asymmetries and how to minimally correct that and still keep themselves comfortable, because just corrections in posture can contribute to strengthening the muscles that are deficient. And then we take a look at their core and make sure that there's no, severe deficits, because core strengthening, even though it sounds a little bit foreign to people, is actually really, really, really achievable. You can do isometrics in your car on a long drive, and it actually can help you quite significantly in your life.
So, you know what, as ironic, I'll tell you something. I think people hear core strengthening all the time, and it becomes this generic, like, can you
planking.
But you just mentioned three things. Yeah. The chin tuck. What was it before you said?
Slouch correct.
Slouch correct.
So easy.
Chin. But can you demonstrate? I'd like to see it.
Sure.
Because I'll be honest with you. Like, you hear these terms in core strengthening. I think that means a lot of different things to different people, and I know how critical it is. Can you show those two things?
Sure. Actually, this is one of my favorite things to show, because people think of a chin tuck as actually tucking your chin.
That's what I would think of it as.
Right. And really what you want to do is achieve this really nice, upright, neutral posture. Okay. And you pretend that your chin and your neutral head is on a tabletop, and you move your chin off the table and back on it.
That's a chin tuck?
It is a chin tuck. And if you hold it, you actually get more benefits. Can you see that okay?
Yeah.
Yeah, so that's a chin tuck, and it's really achievable.
I just learned
really
something.
Helpful. Oh, I'm so glad.
And I know why it's helpful now as a neurosurgeon, because that problem with that nerve root, if on that image, is being squashed through what's called that foramen, right? So what you just did is opening up that foramen.
Yeah, it gave it a little help. Yep.
It's literally opening up that foramen and taking that irritation and inflammation off. That's really interesting.
Additionally, not only opening up the anterior portion of that, but you get a really nice stretch of these suboccipital muscles that get overused, especially if you have poor posture.
Right.
And that can also be irritable and cause a lot of pain as well, especially if you're, making accommodations to your posture because of the pain.
So how often should, again, this is your patient, they're having that. How often do you tell them to do that?
I tell them to hold up to 6 to 10 seconds, depending on their comfort.
Okay.
And 10 times, and they can do it throughout the day.
So as much as...
Especially if there's desk work happening and I can't do an ergonomic assessment.
Right.
Put yourself in upright posture, give yourself a little bit of a check, and make sure you're doing those chin tucks. It will set your spine nice and straight and give you a good starting posture so you can continue to work.
So hold it for
6 to 10 seconds, depending on comfort.
Seconds.
Yeah.
And
6 is the minimum.
Okay. And then just as often as you can.
10 reps, and when you think of it.
So 10 reps, okay.
Yep. Of course, if it's exacerbating your symptoms or getting a little bit uncomfortable, then you take a break from it. But it really is a very, very benign, helpful exercise.
Wow. I would have never, because I know the chin, I would assume that it was a chin tuck.
I'd say 99.9% of the population does.
And then the slouch.
So a slouch correct is when you sit and you actually slouch forward. Right. And I have patients put their hand in the small of their back. You sit all the way upright, almost overcorrect, like beyond military posture. Take a deep breath. Exhale, and you just want your hand to comfortably sit in the crook of your back.
Okay.
And then you hold that. That's also very helpful. And isometric contractions are when when your muscles are contracted and held for a period of time.
Right.
That's a strengthening
like a plank.
exercise. Correct. Exactly.
Right.
It's a strengthening exercise, and it sounds so simple, but the muscles, the deep muscles that are engaged when you do something like that,
right.
It's unmatched, those exercises, and they're wildly beneficial.
Right.
So a slouch correct is just as simple as that. Again, you hold it for about 10 seconds, a little bit more if you can tolerate.
Right.
It does kind of get you get a little bit achy initially when
As
you're
you
just
should,
implementing
right? That means
these.
it's working.
Correct. Yeah. And again, that's something so easy, but you can do all day, especially if you work at a desk and you have pain associated with your work.
Right. That's fantastic. And that, in a sense, is not a sense, that is the core strength, right? So your core muscles are being worked by these types of isometric.
Correct. It's the simplest activity. I mean, you can be very innovative and inventive with core strengthening, but just as far as like a reset, you can't get more simple than that. Do it in a car, do it at your desk, like I said.
So can you talk a little bit about isometric?
Sure.
Therapy as well as exercise? Because I can tell you personally, I used to do sit-ups and all stuff. Starting to, using things like planks and that, it's incredible. And it's not intuitive. It's really not intuitive. No. Or yoga for that matter.
Correct,
right?
Yeah.
Because yoga Pilates in itself is holding a certain position, which is an isometric. And it really is amazing. And I think it's, again, from my standpoint on my side, I think it's so underutilized and poorly understood. Where and when people think of physical therapy, I don't think they think of that as the core strength and all the isometric. Can you speak a little bit to how it's used and how it's helpful?
Sure. Anytime you contract a muscle, right, you're engaging those motor units of the muscle, and they respond to that, and you build a muscle based on contracting it, right? Like when you're lifting weights. That's not the only way. That's not the only way to get resistive exercise. Mm-hmm. If you contract your muscles, something like contracting your belly button, an exercise that I give to patients is I say, pretend that there's a rope through your belly button coming out your back, okay? And someone's playing tug of war in the front and tug of war in the back. And the back is winning. It's just a little bit of a visual because when I want them to engage their deep abdominal musculature, I don't want them to bear down necessarily, like they're having a bowel movement or something. I want them to engage their flat tummy muscles back towards their spine, because it's very difficult with a simple sit-up to get all of those layers of muscles and really, really engage also your spinal stabilizers. But doing an exercise like that, like I just spoke of, engages all of that deeply. And it's a strengthening exercise if you hold that contraction, you do it appropriately. And then if you do it for repetition, it's equivalent to weights.
Right.
You're recruiting those muscles to work.
Without the excess wear and tear on your joints, on your spinal column, on your because I think weights, and I'm curious on yours. I think running is running and weights are a great. I think the young person, you see it, but I can tell you from my standpoint, from both being an old person and also from patients and seeing it, there's a lot of and I think we're realizing that now. Wear and tear that becomes detrimental.
Sure, absolutely.
As opposed to what you're describing, aquatic therapy, resistance, where you're not giving that excess trauma.
Yeah, anything with high impact. I mean, I will say myself that I'm a runner, and it has gotten more difficult with age. I'm 43 years old now, and I do have pain when I run, but I do it because it's part of my soul. It's not a recommendation for someone to pick up later in life. There are so many other options to keep yourself healthy, to keep yourself strong, fit, and just well-rounded as an individual. But I think that people often, forget that there's more to it than just hopping on a treadmill.
Right. Right. So again, I want to focus a little bit the things that we talk about now about weight loss, about healthy eating, about diet. There's our world of where it's easy to say, right? And then there's the patient, where in the best of intentions, where patients really do try, but they're fighting sometimes genetics, lifestyle, sometimes socioeconomic, where, as we all know, eating healthy is not cheap.
No.
And it's kind of counterintuitive. So there's that. And then there's the acute. There's that acute exacerbation of, and to me, that's where I see patients getting into trouble. And when I say getting into trouble, the thing that brings patients in to see the doctor is pain.
Yeah.
It's not, oh, this could happen. Or I've had patients who literally cannot hold a glass of water or a bottle of water because they have such hand atrophy, and they just kind of blew that off. But when you start having pain,
Sure,
that's what brings you in. So those patients, to save them from an unnecessary surgery or any type of procedure. I mean, even an injection, which again, I'm a surgeon. I want to be very clear. I'm a surgeon. I like fixing things. I like fixing things with, acutely. But outside of, and we'll talk a little bit about that, about patients that do need to be addressed because they're, losing motor strength, things like that. What are some techniques? What are some things that, again, specific to whether it's diet and all those other things, those take a little bit longer. But
they do.
Medications, as far as non-steroidals, as far as position, like what's your recommendation for that cookbook of acute exacerbation?
So I really think it's imperative to take a look at your diet. And I know that's really, really difficult. But there are things that you invite in your body that systemically inflame you, right?
So let's talk about that. Yeah, what are some things that...
So sugar, it causes, demise of a lot of systems. You really do have to watch your sugar intake. I know that it gives you some quality in your life. I'm not saying give it up forever. Not saying give it up altogether, but in moderation for sure. And I don't mean moderation, you eat it, once every night.
Yeah.
I mean, really, sacrifice and understand what it's doing to you systemically. Food can be medicine. It should be viewed that way. Alcohol is another, an inflammatory product that we invite in and that causes serious inflammation. And carbohydrates, of course, right? Yeah. So you should have a very, very well-balanced diet. You should watch your protein intake. That helps you develop muscles. It helps all of your body systems work efficiently. It's imperative to understand that what you put into your body can help you or hurt you.
So it's real. The three things you mentioned are carcinogens.
Correct.
And they are carcinogens.
Yeah.
And it's not a big surprise why we have, the juvenile diabetes, obesity, all of these things are linked to essentially, I strongly believe, and I think the data, real science is supporting is sugar, is lifestyle, as far as, sedentary lifestyle. Alcohol now we really know is, this gone from double-edged sword where people read it's, the Mediterranean diet and this and that.
A little bit of wine.
There's a balance, there's definitely a balance. And I think you always hear, well, I know my grandfather who's, 90 years old and he smoked a pack of cigarettes a day and he drinks, he has a port every night before he goes. There's genetics, there's definitely a component, but those things are triggers for a whole cascade of cellularly in the body, physiologically, that trigger things. And so the sugar, I'm so glad you brought that up, because I think sugar is so bad for you. And I think you can moderate it very well. And it's tight. So can you talk a little bit about, all sugars aren't the same, right?
Correct.
Fructose, the sugars in complex, the complex carbohydrates, a
lot of effort for your body to break down and utilize efficiently.
Right.
Yeah. Of course, fruit is a wonderful sugar. There's so many vitamin and health benefits, nutritious benefits. That should also be, taken in moderation as well.
Yeah.
Yeah, because it is a sugar and it is an effort for your body to process that.
Right.
But if you have to pick any sugar, that's the one to choose, right?
And of the fruits.
Yeah.
So I think if you take something like watermelon.
Yeah.
Oranges even are kind of up here. And then you take things like blueberries, blackberries, raspberries. You can see glucose spikes.
Yes.
Depending on, so all fruit's not the same, right?
Correct.
So what are healthy fruits for?
I'd say any berry, obviously. If you have a colorful plate, if you're ingesting a colorful plate for your meals, then you're winning.
Right.
Right? So fruits and vegetables, a really nice mix, and then a hefty dose of protein as well, obviously.
Right.
But any berries, you're really not going to lose because there's really robust antioxidant qualities and vitamin qualities in those fruits.
Right. And the antioxidants, for the listeners, are really important in inflammation.
Right.
And radiculopathy, back pain, neck pain, even if the nerve root's not being compressed, your joints rubbing up against each other causing low back pain, because there's the majority of people with pain, neck pain, back pain, have completely, maybe not completely normal MRIs, but don't have nerve root compression, there's an inflammatory process at a physiologic level that's happening.
Correct.
So again, the diet is really important. So we talked a little bit about neck pain, back pain. In your experience of what you see, I mean, how much of that is related to posture, to, again, all people being, you have a laborer who's, lifting all the time, and that's one thing. But, the average person who has, normal activities, fairly healthy, is it postural? Is it weight? Is it, activity?
I think it's a combination. Back pain, the complaints of back pain come to me often, more than neck pain. I would say 4 times a week. I hear people complaining of back pain, all different ages and backgrounds, right? And I do think that it's multifaceted. I think that it can be, related to, again, unhealthy habitus and a little bit of extra weight in your abdomen.
Right.
And then just other things that contribute.
Right. So getting back to treatments, what kind of recommendations do you have for in conjunction with physical therapy? Do you recommend that patients start any type of, again, like non-steroidals or anything like that, in conjunction with physical therapy? Or do you say, let's try this, then we go to this, then we go to this?
I would say if you're in an acute exacerbation, it really is affecting your quality and your sleep and things like that. Sleep is also medicine, right? Quality sleep.
That's one of the things I want to get to, yeah.
Okay. If it buys you a little bit of sanity and a little bit of time and a little bit of relief, by all means.
Right.
But otherwise, there's pretty, like I said, innovative interventions that we can provide that really do offer relief. And I'm not saying it's magic. Nobody has, pixie dust or a wand.
Right.
It does take some patience, but if it's done right, you will see relief.
What are, just like, there's I'm trying to think of a politically correct way to say this. There's a lot of, let's just say, bad medicine out there.
Okay.
From surgical to medical to everything. There's just a lot of, and I truly believe it's not intentional, but I think there's just a lot of misinformation. There's not a lot of clear data on things. That's why I love those publications, which was such a blast to the surgical spine community and I think which I do think most of the surgeons are want what's best for their patients. And I would like to say all of them do, but you only know what you know.
Sure.
And I think there was this kind of epiphany of like, wow, not that I think everyone understood that physical therapy was important in work, but that as a surgeon, you see something where, wow, this is pushing on a nerve root and, surgery takes care of it. And, at the end of the day, post-operatively, our patients are like, wow, my pain's gone. But what happens after a year? What happens after 2 years? What happens when that instability now becomes, well, you need a fusion because there's movement here. And, nobody wants to talk about it, but the truth of the matter is surgeons are incentivized financially, and institutions are incentivized financially for doing more surgery. And again, I will tell you that the surgeons that I know and almost everybody I've ever met always wants to do the best thing for the patient.
Absolutely.
And that's not the number one driver. That being said, our healthcare system incentivizes. So if a surgery is being done and you do 1 level, you get X amount of dollars. You do 2 levels. The more surgery and the more levels you do, the more money you get. I don't care. I mean, God created us not perfectly. And at the end of the day, it becomes a very slippery slope. Well, 10 years from now, you might get instability. So I grew up in a world during surgery where, the first metric was you do not treat films, you treat patients. I don't care what the MRI, the CAT scan shows, you treat the patient based on their symptoms. Yes, there are emergency flags of things, but for the most part, you have to focus on the patient, the symptoms. Do they have these red flags? Weakness, problems walking, bowel bladder, those type things. Outside of that, you're focusing on how do I get the pain better? And surgery is not the first choice. But if there is surgery, I think we got into this instrumentation of, again, putting in screws and plates and all that. Most of that is done, and I know I'm going to get a ton of kickback from my surgical colleagues, but most of that is done for preventative. We're going to decompress this, but you might become unstable down the road, so we're going to put in this fusion. Like that becomes a really slippery slope. So I think on my end, we see that, and I think we need to do better, and we need to use better data. We need to do, I think, more collaborative work. And maybe this is a thing that we can offline. We can talk about some studies we can do, because I think
there definitely needs to be more,
and it's not going to be done unless we do it together. Right. What do you see on your end? Because I see a lot of people that come to me and they're like, the physical therapy is just not working. I don't like it. Or I don't like my physical therapist, just like the doctor, And sure. What do you see on your end that becomes things that, I wouldn't say that you would criticize, but that are where patients have a bad experience with physical therapy and opportunities? Exactly.
Sure.
Because I don't want patients giving up on physical therapy.
I don't want that either.
Because they maybe had a bad experience,
sure.
or they went to somebody who specializes in concussions and head injuries, and you know what I mean? Like there's apples and oranges.
Yeah, of course. I would say that you have to give it a chance, right? It does take patience. There is no quick fix. If there was, we'd all be using it, right? We would all know about it. It would be advertised on billboards and such. So it does take some patience. And again, it's not cookie cutter. So sometimes there is a little bit of trial and error to see what works.
Right.
And it takes time to see what works. And then you can tap into that and kind of build on it, right?
Right.
The nice thing is there's a million clinics and physical therapists.
Right.
You're able to shop around. If you don't have, and you need to trust the person that's treating you, they're a provider, right? So if they're not your cup of tea, or they're just not tapping into the deficits that you have and you're not seeing optimization and turnaround, then you have options. It's a beautiful part of life, right? You certainly can shop. There are specialties for physical therapists. There's an orthopedic specialty, and there is a specific spine specialty as well. So if you're looking at clinics, they do divulge people that work for them and their specialties.
Right.
So that's something that, patients can look into as well if they want someone that treats specifically spines and radicular pain.
And what was for the patients that are listening, and the healthcare providers that are listening, what is the referral? Like, what do you say? If I'm a patient and I'm calling and I have back pain and I want someone, what is there?
An OCS is for orthopedics. Yep. And
so OCS stands for
orthopedic clinical specialist.
Okay.
And then there is a spinal manipulative therapist, an SMT.
Okay. Yeah. And see, I think those are things that I don't know. And I see, a lot of people with these types of issues, and my colleagues do as well. I think what's really unique about what we're doing at AtlantiCare and is that we work together like this. So I don't have to think about those things, because I know when I send patients to you and your team, you guys figure it out.
Sure.
Like they immediately, and there's a communication where there is, so critically important to have that, because I get a lot of calls and my team gets a lot of calls from physical therapists who are in a really, which I love. They're like, I know this is what I want to do, but I saw this MRI report and I want to make sure that I'm not going to overdo it for the patient, or even if they're comfortable with it and it's like, I'm doing these techniques and, there's the patient's having a lot of pain with it. Is this okay? That communication is rare. But it's so critical.
It is.
So I think that's why I want to make sure, to your point, that if people are getting physical therapy, they should also ask their provider who they recommend and
Absolutely.
who do they work with and who do they have that communication with, as opposed to a script, which is what happens all the time. Oh, you need physical therapy. There's nothing specific on there. Barely even a mention of what the issue is. Physical therapy. And then the patient's stuck in the middle of like, okay, to your point, there's 10 billion, you can't throw a rock and not hit somewhere where there's a physical therapy, whether it's in a strip mall, part of the healthcare system, clinics, or a big system. So, where do you see the biggest need is for collaboration? In your perfect world, if you could design a center, what would it look like?
Equitable care for the patient, equitable, collaboration, I think. I think that we are in a really, really unique situation in our healthcare system where my very large rehabilitation team of clinicians they're viewed as providers and their recommendations are valued. I don't think that is the culture, certainly nationally.
Right.
That would really, there are, just like any other specialist, there are really, really important pieces of the patient case that physical therapists, occupational therapists, speech therapists bring to the table. They're incredibly valuable. And I'm forever grateful that, we personally live in a world where those conversations and that collaboration exists, but I don't think that's common.
No.
And to take care of the patient to the best of our abilities at the highest quality, that needs to happen.
Yeah.
Open communication, open understanding. It may be that we or providers don't know everything about the therapies, right? Yeah. I think that more or less some people that aren't, so engaged with rehab services or physical therapy as the outpatient, they think we pick people up and put them down.
Right.
And it is a much deeper dive than that. Yeah.
I wish, I wish we could show some examples. And again, for the viewers, something that we have at AtlantiCare, which is just, I think, and I've been doing this 30 years, is we round in the morning with either you physically yourself or one of your team members every morning, 7 days a week, from the sickest of sick patients. And I think that's where it starts, right? That's where the plan starts. And I'll tell you what comes to mind, and not to get off topic of neck pain and back pain, but I remember this 19-year-old girl from Lithuania who was here.
She was incredible.
Tragically got shot by somebody who was a drive-by shooting in Wildwood. Came in a coma. I think for most places probably would have just said there's nothing to do. Literally came in a coma. 19-year-old girl, dominant hemisphere, which is where our speech is located, our right side of our body. I operate on her at like 3 a.m, and I would say 8 a.m., 5 hours later, we were on multidisciplinary rounds. Your team, I think you may have even been there.
I was there.
Yeah. And we immediately started speech.
Yep.
Working with that right side. And she's walking now.
She's impressive.
She's
Incredible
walking.
recovery.
She's back in Lithuania. She's functioning. She wants to go. I mean, I can tell you, we get all the act. Oh, you say, she would not be where she is if it wasn't for the rehab. I mean, for me, like taking off her skull, that's the easy part, really. I mean, it sounds funny to say, that's the easy part. It's that understanding and focus therapies for speech, occupational, motor, that core strength of losing, and in a healthy 19-year-old, and not everyone gets there because not everybody gets that kind of care. Yeah. So it really is a unique thing. And I guess that's what we have to focus on, inpatient, but then outpatient as well.
Sure.
Of bringing these centers together.
It's a matter of trust, right? It's a matter of understanding that you all bring a very valuable piece to the patient's story.
Right.
And valuing that. And like I said, open communication and just understanding that you're all there for the betterment of the patient.
Right.
And it works. It does. It's a beautiful story. And I will not let you say that you did next to nothing. You saved her life.
No, I mean, and I'm not saying this to be glib or
No,
anything, but I mean, it
course.
really is. I think that the messaging gets lost because I've been doing this a really long time, and I've seen the difference of people getting the right outcomes based on the type of therapy they get. And, as you know, it can be a battle with insurances. It can be a battle of, access. And
Absolutely.
sometimes just a spin of the wheel of what system you end up at, what, type of care you're getting and all that. And I think it starts acutely. So getting back to just to kind of to circle back and kind of, again, for the educational standpoint, what are I'm going to give 30,000 foot and then a little bit more granular. The 30,000 foot, what would be the top 3 things that you would say to, again, this is that's why I'm saying 30,000 foot. Now, understand there's different ages and physical, but top 3 things for spine health to avoid ending up with that disc on your, on your MRI. What are the top 3 things people can do to prevent?
Be conscious of your weight, right? And how your body is built. Your body is not meant to carry a hefty amount of weight on the front, right? It puts enormous strain on your spine more than any other body part. So you really do have to be health conscious and maintain a healthy weight. Also, your composition, you should have strength and musculature. Our bodies are machines. They want to be strong. They're meant to move. And you have to keep them optimized so they can perform for you, right? So that's how you have a quality life.
Right.
I also would be very, very mindful of, like I mentioned before, what you put in your body, right? You don't want to invite in more inflammation. There's opportunity to be inflamed with stress and navigating life as it is. So food is medicine, and it should be treated that way. And then additionally, you really need postural health. Postural health and strength around that postural health. We live in a
Am I giving you chest pain right now the way I'm sitting?
Not at all. We really live in a forward flex society, right? We're on electronic devices.
Very much so.
We're on phones. Your body does not want to be that way, and it definitely invites in pain and dysfunction at so many levels, but especially to your spine that's struggling to live here, right? So really a nice look and to make sure that you are symmetric and structured, and that you should, when you look in the mirror, you should be proud of the body that you see, upright and just ready for life.
Right.
Yeah.
So that's awesome. And I think those 3 things are all connected, right? I mean, one you don't get without the other. So I think that's a great overview, but going through each one just briefly. So when we now have the, the Ozempics, we have the GLP. So at what point do you recommend, or do you ever recommend?
I think it's case by case. I really do think that people have to have strong relationships with providers if they're having that conversation. I don't have strong opinions on one side or the other. Just like any medication, you are inviting in risk when you take any medication, as simple as over-the-counter Advil, right? Right. So I think it's really important to do your research, to dive in deep, and to trust your provider and have really granular conversations to make the decision that's right for your life.
Yeah, no, it's a good, because there is no one answer. There's no one pill. Every action has a reaction. Everything's a risk and a benefit.
Sure. You have to weigh it out.
As far as exercise, so you're obviously an incredibly health conscious person. You exercise, not everybody, most people can't do that. And so what do you recommend for the average person who is busy managing a family? What are some exercises that you would recommend that are just simply that anybody can do from 90 to 9?
So I always start with walking. Not only is it excellent for you to get out and get a little bit of air and sunshine on your face, or if you like to walk at night, that's beneficial as well.
Why is that?
just to change your environment, change your
At night,
headspace.
I meant specifically.
I mean, if that's what your schedule allows.
I see.
Right?
I see. Yeah,
You don't get the benefits of the sun, but you still get benefits of being outside, changing your environment, your headspace. There is a systemic response, a physiological response to breathing in air, right? The outside air.
And we also know, I mean, I can tell you from a neurophysiologic standpoint, exactly right. Walking out on a day where the sun's out, and there are endorphins that are released that are very, very beneficial. So that's a really good point. Yeah, the walking and...
So walk, and whatever you can, even if it's around your block or, just a short bit, if you have 10 or 15 minutes, the kids just went to sleep, like I said, at night. Find it, fit it into your week. I just gave my parents, who are incredible 73-year-olds, both of them. They work out every day, 7 days a week. Yep.
So that's where you
eat
get
very
it from.
healthy. Yeah. They're in incredible shape. They travel all the time. But I told them that they have to incorporate sit to stands and high reps of them. So literally sitting in a chair and standing. I gave them something like 100 reps to do. And if they can, I know it sounds absolutely ridiculous, but
are they like hiding from you now?
It's so easy and you can do it.
100 reps?
Yeah. I mean, and it can make you a little bit sore, but the stronger that you keep your legs and the stronger that you keep your gluteals or your butt muscles, the more longevity that you have.
So it's literally just sitting and then standing.
Yeah.
Sitting and then standing.
So simple.
No, I mean...
Certainly you can add weight to that too, but if you want the most simple solutions for every single day that you don't need equipment for, anything like that,
right,
by all means.
That's
planking.
fantastic.
Yeah, planking is also very helpful. You don't need equipment for that either. You do have to have good technique though. Good posture. Your back shouldn't be, in a sulcus or anything like that.
How do you know you're doing it well?
In front of a mirror, or you have a friend kind of look at your posture. You want your spine to be in alignment. If a true plank, like on your elbows and on your tiptoes, is too much and it's too taxing, then you can do what's called quadruped, where you go on your knees and your hands. You're still engaging your core.
Right.
You have to start somewhere, right? Yeah.
And you should feel it, right?
Absolutely.
Yeah.
Absolutely. I mean, these are really, really low level activities, but
Right.
if we're starting from the absolute basics and you're just looking to do something as opposed to nothing, start here. Right?
That's great. Those are really great because everybody can do that.
100%.
Right?
Yeah.
And so that's the kind of 30,000 foot. And then getting to the granular, what would be the top 3 things that you would recommend? Again, someone's passing you in the hall at work and is like, I've got this horrible neck pain. It's going down my arm. I had an MRI. It's the doc's just telling me it's radiculopathy. What are the top 3 things that person can do?
So I always give them slouch corrects, like we had just talked about
which
before.
Is great.
And I will give them chin tucks too. Have them do it in front of me to make sure that I'm not recruiting pain.
Right.
Typically, I would say I've never seen an increase in pain symptoms with something as simple as that.
Right.
And then sometimes based on what I see, if there's issues with tissue extensibility, if they're tight, I will give them like nerve flossing exercises.
What is that?
Those are really specific exercises to keep your nerves running nice through the foramen.
Okay.
It really
I've never heard that
on
term. I love that. Nerve flossing. I love that.
You can look them up on YouTube or something like that.
Right.
There's some really, really credible resources out there. But additionally, if I see any dysfunction or weakness and the person has neck pain, but a healthy shoulder, I always give wall push-ups. And it sounds ridiculous, but I have them engage their belly. These are the strongest young dudes you've met.
Yeah.
Okay. Wall push-ups with good technique, a straight body, strong core, belly button to spine, with an extra serratus plus. So you do a wall push-up and then a little bit of a plus. You can do high reps of those.
Right.
Not only are you engaging your core, you have to keep an elongated neutral spine and you're strengthening around that. You can't put your head into the wall.
So you're not like leaning into the wall. You're standing straight.
No, it's a nice straight spine. They're so easy. Again, no equipment, accessible anywhere.
Right.
Very, very, very easy to understand the technique.
Right.
And you can go up or down on reps based on your tolerance.
Wow. That's a great, I have not heard of that one. I mean, I know of it, but I mean for, using specifically for neck pain, back pain. That's fantastic. So, and then as far as, so those are maneuvers. And for the listeners, we're going to get links so that you can see.
Sure.
We'll get
Sounds
you
good.
links so that you can see all of this. Get information about these specific techniques. So what other things, as far as what do you recommend posture-wise? Sleeping. That's a big one. We get a sleep position.
Absolutely. I would say if you're waking up with increased pain and that's where your pain is primarily presenting, then you need to take a good look at how you're sleeping. Is your mattress too squishy? Do you have too many pillows? Do you not have enough pillows? Is your pillow like a marshmallow? And do you need something a little bit more firm? There's definitely options and solutions there. You can Amazon something that you think may work for you, right? But you do need to really hone in on maybe the habits or the repetition of what's causing your pain so you can find a solution.
So I guess the idea would be to keep as neutral as possible during sleep.
Sure. I mean, you want to be comfortable. You certainly don't want to sleep on anything too stiff.
Right.
It's not comfortable and doesn't hug your body as well because your spine has natural curvature, as you know. But I do think that there's a happy medium there.
Right.
Yeah.
Because I'll tell patients because we do know, right, our neck position is mobile and those foramen open and close based on our position. So sometimes, people's heads are either cranked like this or pillows that are, too much, or to your point, too squishy where you're back like that opens and closes the foramen. And depending on laterality each side, this is going to open, this is going to close on each side. So that's great. So, this is great. I mean, I actually learned a lot here. I did, which is pretty funny. Again, I've been, every time you think you know things, it's like, at 30,000 feet, but this is awesome. So for the listeners, so let's switch, we'll kind of close with this. And I know these are going to be a lot of the questions. What do I need to be worried about? That's usually what it starts off with. Because anytime I see a patient in my office with radiculopathy and they have an MRI, and some of these reports make it sound like you literally are going to be in a wheelchair.
Detrimental, right?
Yeah,
like
which is fine. But I mean, you have to interpret that with patients because, again, I'm an old guy. Back in the day, patients never saw their reports. They never saw. Now everybody sees their reports, which I think is a good thing.
Yeah.
I love transparency, but you have to explain it because people are freaking out. There'll be spinal cord compression, severe radiculopathy, severe foraminal stenosis. All these things are radiographic reports. You have to put them in context.
Okay.
So the first thing I usually do is just tell my patients it's okay. You're not going to wake up paralyzed. Nothing bad's going to happen because you have to get them over that fear. When anytime you hear any type of neural compression, right? Appropriately, people are freaked out. So it's kind of like, look, this is where we are. This is okay. And then it's the things that you do need to be on the lookout for. So what are the things that my antenna go up? And those are motor weakness.
Sure.
You start having weakness, not weakness from pain, right? Where you're limited, but you're dropping things. You can't lift your arm up, your leg's weak, you're starting to trip, you're falling.
Buckling, yep.
Bowel, bladder symptoms.
That's right.
You start to have incontinence where, you're leaking, man or woman. Bowel incontinence is a big one. And those are obvious things.
Or bladder retention.
Retention, chronic constipation, anything that's affecting your bowel bladder that's unusual. There are certain things that are emergencies, like something called a cauda equina in the back where the spinal cord, it's not a nerve root being compressed. And then the things that you see where you start having things, and that's more chronic, like atrophy, fasciculations where you're getting twitching, things like that. But the big ones are really weakness. I mean, those are the things we need: motor weakness and bowel bladder symptoms.
Yeah, or really, really severe changes in sensation, right?
Yep.
Anything that's really different from your baseline health and your baseline function are big things to pay attention to. You don't sit on them. You have a conversation and a face-to-face with a provider.
Yeah. And sometimes, the irony is that what brings, again, patients is the pain, appropriately, because that's what really affects your functionality. And severe pain is subjective, right? My 10's different than your 10. My 2 may be your, 5 and vice versa. So, and imaging is critically important. You know, always, the reason we start off with an MRI is because it shows these types of things. It shows the nerve roots and all of that. Mm-hmm. So, well, this has been awesome. I can't tell you how happy I am. We'll do a couple more series, I think, because I'd like to delve in a little bit more about how, you know, the functionality of programs, of how we can kind of, you know, do a better job for patients, and then maybe get into things like brain, you know, speech, brain injury.
That sounds great.
And then I think healthy living as well, because we're working on a wellness center together with AtlantiCare so that we can do this holistic approach. Yeah. And we'd love to get feedback from our listeners so that we can, you know, everything we do is based on feedback from patients. And I think I remind people all the time, you and I as healthcare providers, we're patients. And our family's patients. Yes. So it's not like we're in this different bubble. Like, we experience what you experience, we live what you live. And so, you know, feedback is critically important.
Agreed.
And again, you can look at the bottom of the screen for any type of all the links to the various centers and ways that you can connect with Dr. Previti directly and her team. And again, we're one team at AtlantiCare. And hopefully we're going to be soon to a neighborhood near you. Great. Thank you very much for joining.
Thank you so much for having me.
You're welcome.
It was a pleasure.